This is a 50 years old male who is a diabetic and a smoker and hypertensive. He presented to the emergency department with typical chest pain, and on ECG found to have ST elevation in the inferior lead. So it's been 4 hours. He is suffering from the chest pain, so we took him, explained everything and took him for the angio. This is angio. This is the LO caudal view, and you can see there's a significant lesion in the LAD, mid LAD, almost 80-90% stenosis in the mid LAD. This patient is a diabetic, uncontrolled diabetic. The same thing you can see in this RO caudal view, significant lesion in the mid LAD. And now clearly you can see there is a significant lesion in the mid LAD which has to addressed. And as expected, there is a total thrombotic occlusion of the RCA in this shoot. This was a right radial root. This is a Tiger catheter. You can see how bad thrombus is there. So after all clearance, we took up this case with same route, right radial route. Generally I do with radial route because of the less complications compared to the femoral route. So with right radial route, this is a JR catheter, and this is a BMW PTCA wire. It was a cakewalk to cross the wire easily, and you can see after crossing wire there is no flow even. In such a situation, if patient presented within the 4 hours of chest pain, so the thrombus is very friable and it can go here and there. So if there's no flow after crossing the wire, then we can do the balloon daughtering. It's very risky to do balloon daughtering in this acute setting, but there was no way, so we had to do balloon daughtering. This is a balloon daughtering. Balloon daughtering is a to and fro motion of the uninflated balloon in hope of getting flow. So this is a balloon daughtering I have done with a simple 2.0 balloon. But even after balloon daughtering, there is no flow, you can see. So again I did a second run of balloon daughtering, and then hereafter we got a flow in the RCA. There's always chance of no flow, reflow, slow flow in this acute setting, so should be very careful and we have to address it. So we have given Terifibran, Nicoron, everything after this, and you can see the size of RCA is almost 2.753. So this is a cranial view, and you can see the plaque rupture site. It is just after the ostium, just in proximal RCA, as you can see. In this epicranial view, we can see in the proximal RCA there is a site of this plaque rupture. So the stent of 3x28 taken, and this is the positioning of the stent. After ostium, you wanted to put a stent, wanted to deploy. So this was a 3x28 stent, and we deployed it at around 16, that is RBP pressure. 8 was nominal, as it was the proximal RCA. So generally I don't do a predilatation in the acute setting, because with the predilatation there is a pre or post dilatation, there is a chance of no flow, reflow, because of this bad thrombus. And this is a flow after the stent deployment. You can see some sort of spasm is there at the ostium RCA, but that is okay. So here you can see the TME3 flow in the RCA, and some sort of under deployment is there in the stent, but it is acceptable. Already we deployed the stent, inflated the stent at RBP pressure. That was twice we inflated. So this is the final scene as an acceptable result in the ACS condition. So this was a sort of primary angioplasty to the RCA, this inferior wall ST elevation MI. You can see how dominant the RCA is. You can see the PDA PLV, how large it is. We started this patient on the terrific band and patient is stable. After placing wire, there was a bradycardia at around 30-40 heart rate. So we have given atropine that time. So generally it is normal during the ACS angioplasty. So now patient is stable, heart rate is around 100 and BP is 140. LV function is mild LV dysfunction. So this was the primary angioplasty to RCA. Thank you.